Good afternoon, everyone. My name is Nina Bondarenko, and today I'm glad to read you my lecture that's dedicated to inflammation. My lecture includes the next outlines: general features and causes of inflammation, acute form of inflammation, chemical mediators and regulators of inflammation, systemic effects of inflammation, morphological patterns of acute inflammation, and chronic form of this pathological condition. The survival of all organisms requires that they eliminate foreign invaders such as infectious agents and damaged tissues. These functions are mediated by a complex host response called inflammation. The definition of this entity is a protective response involving host cells, blood vessels, and proteins and other mediators that is intended to eliminate the initial cause of cell injury, as well as necrotic cells and tissues resulting from the original insult, and, what is important, to initiate the process of repair. All the inflammation helps to clear infections and other stimuli and initiates repair. The inflammatory reaction and the subsequent repair process can themselves cause considerable harm. The nomenclature used to describe inflammation is different, employs the tissue name and the suffix itis. I guess you know this. So we use, for example, such terms like pancreatitis when we mean the inflammation of pancreas, meningitis, pericarditis, and arthritis. The components of inflammatory response include circulating cells and proteins, cells of blood vessels, and cells and proteins of extracellular matrix. For example, macrophage may eliminate microbes and dead tissues and source of mediators. And these mediators that can be released by macrophage are organized the start of inflammatory response. Mast cell is a source of mediators, lymphocytes and monocytes and polymorph nuclear leukocytes responsible for the next steps of inflammatory reaction. So all these cells and tissue components together organize and orchestrate a complex inflammatory response. Before we describe the process of inflammation in detail, some of the basic features I want to highlight with you. First, inflammation can be acute or chronic. We know two types. Acute inflammation, usually short duration, and represents the early body reaction. This type of inflammation, characterized by fluid and plasma protein exudation and a predominantly neutrophilic leukocyte accumulation in the area of injury. Chronic inflammation, longer duration, characterized by longer duration, days or years, and is typified by influx of lymphocytes and macrophages with associated vascular proliferation and fibrosis. But as we will see later, these two basic forms of inflammatory reaction may coexist, like chronic active inflammation. So this table compares these two types, and as you can see, onset of acute inflammation fast, while chronic slow. Cellular infiltrate, mainly neutrophils content, and monocyte macrophages lymphocytes during the chronic inflammation. Tissue injury and fibrosis, usually mild and self-limited during acute inflammation, but during chronic form of inflammatory reaction, often severe and progressive. local and systemic signs of acute inflammation prominent, and the less prominent during chronic cancer, chronic inflammatory cancer. Next basic feature is inflammation is induced by chemical mediators that are produced by host cells in response to injurious stimuli. When a microbe enters tissue or the tissue is injured, the presence of the infection or damage is sensed by resident cells, and mainly macrophages responsible for that function. But also dendritic cells, mast cells, and other cell types may welcome the foreign invader. These cells secrete molecules like cytokines and other mediators that include the regulate the sequence of inflammatory response. The external manifestation of inflammatory reaction, often called like cardinal signs, and there are 5 cardinal signs of inflammatory reaction, like rubor, tumor color, dolor, and functional lesson. So rubor means hyperemia, color means local hyperthermia or fever, tumor means tissue swelling, dolor pain, and functional lesson means loss of function. Next basic feature of inflammation is inflammation normally controlled and self-limited. Now it's time to talk about causes of inflammatory reaction. We know infections like bacteria, viruses, and other toxins and parasites. And infection is the most common and medically important causes of inflammation. A fundamental question relating to activation of the host response is how cells recognize the presence of potentially harmful agent, such as microbes, in the tissues, and we will discuss this question during the next slide. The second group of agents that are responsible for inflammatory reaction are immune reactions, also called hypersensitivity reactions, like cell-mediated and antigen-antibody reaction. Third group is trauma, blunt or penetrating, and various physical and chemical agents. Tissue necrosis either may be a reason of inflammatory response, doesn't matter which cause of this, and including ischemia like myocardial infarction and physical and chemical injury. And last reason of inflammatory reaction is inert materials such as foreign bodies. So now once again this question, why and how our organism can recognize foreign material and start this reaction, inflammatory reaction. So parasites, dendritic cells, and many other cells such as epithelial cells express different receptors that are designed to sense the presence of infectious pathogens and substances released from dead cells. We know 2 big groups of these receptors, like toll-like receptors that take part during microbial recognizing, and the inflammasome is a multi-protein cytoplasmic complex that recognizes products of dead cells, such as uric acid, for example, and extracellular ATP, etc. Sensors of microbes and dead cells, so toll-like receptors and inflammasome. So toll-like receptors located in the plasma membrane and endosomes, and other cytoplasmic and plasma membrane receptors, and can recognize products of different classes of bacteria and microbes. And the proteins produced by toll-like receptors activation have numerous functions, and As you can see, they may be responsible for cytokine releasing and the activation of the acute inflammation. While the inflammasome is a protein complex that recognizes products of dead cells and some microbes and induces the secretion of biologically active interleukin. 1. The inflammasome consists of sensor protein and adapter and the enzymes caspase 1. So this inflammasome, when recognizes that products or other substances, activate caspase 1, and caspase 1 responsible for activation of interleukin 1 beta form that can be secreted into the surrounding tissue and activate acute inflammation either. So there are main inflammatory cells. I just want to remind you their morphology, because during the next time of lecture we will all the time discuss this question. So polymorph nuclear cells belong to the leukocytes, and as you remember, and characterized by segmented nucleus. That's why polymorph nuclear cells. Monocytes and macrophages are characterized by round-shaped nucleus and responsible for recognition and antigen representing function in the inflammatory response. Lymphocytes, we know B and T form, and B cells are responsible for antibody production. T cells delayed hypersensitivity cytotoxicity. You can find this large blue-colored nucleus and tiny thin area of cytoplasm. So plasma cells is miniature B cells that knows which type of Ig must product and secrete. Eosinophils, polymorph nuclear cells that take a part during allergy reaction, parasitic reaction, and chronic inflammatory response. And basophils, either polymorph nuclear segmented cell with a receptor for IgE molecules on the surface, and these cells may release such mediators like histamine, leukotrienes, and platelet activating factor. So key points of this part of lecture: if the inflammation is beneficial host response to foreign invaders and necrotic tissues, but it may also cause tissue damage. The main components of inflammatory reaction are vascular and cellular response. Both are activated by mediators and are derived from plasma proteins and various cells. The steps of inflammatory response can be remembered as the 5 R's: recognition of the injurious agent, recruitment of leukocytes, removal of the agent, regulation of response, and resolution repair. We know 5 groups of positive agents of inflammatory reaction: epithelial cells, tissue macrophages, and dendritic cells. Leukocytes and other cell types express receptors that sense the presence of microbes and damage. Circulating proteins either can recognize microbes that have entered the blood, for example, like complement system proteins. The outcomes of acute inflammation is either elimination of the stimuli and followed by decline of the reaction and repair of the damaged tissue. Or persistent injury is resulting in chronic inflammation. So now it's time to talk about acute inflammation. The main function, the main aim of inflammatory reaction during acute phase is to deliver leukocyte and plasma proteins in the site of infection or tissue injury. We know 2 major components like vascular changes and cellular changes. Please try to memorize it. And these 2 events are followed intermittently by release of mediators of acute inflammation. So the major local manifestation of acute inflammation compared with normal condition are vascular dilation due to increased blood flow, and this condition causing erythema and warmth, extravasation of plasma fluid and proteins, and edema may occur due to these steps, and leukocyte immigration and accumulation in the extravascular space in the site of injury. Vascular events either can be divided into phases: hemodynamic changes and changes in vascular permeability. Alteration usually connects with microvasculature. The escape of fluid, proteins, and blood cells from the vascular system in the interstitial tissue or body cavities is known as exudation. An exudate is extravascular fluid that has a high protein concentration and contains cellular debris. Its presence implies that there is an increase in permeability of small blood vessels triggered by some sort of tissue injury and an ongoing inflammatory reaction. In contrast, transudate is a fluid with low protein level content, most of which is albumin, little or no cellular material, and low specific gravity. This is essentially an ultrafiltrative blood plasma that is produced as a result of osmotic or hydrostatic imbalance across the vessel wall without an increasing of vascular permeability. So, what I would like to emphasize here: exudate is inflammatory liquid that accumulate in the extravascular area due to increasing of endothelial gaps size and due to high vascular permeability. So once again, exudate, inflammatory liquid. Transudate, characterized by accumulation of the liquid in the extravascular tissue due to disbalance in the hydrostatic pressure and colloid osmotic pressure. So these conditions develop usually due to high hydrostatic pressure and low colloid osmotic pressure. Hemodynamic changes include transient vasoconstriction, it can be seconds or minutes, and after that develop vasodilatation, resulting in locally increased blood flow and downstream capillary bed. The vascular expansion is the cause of redness and warmth of tissue, and as you remember, this is a cardinal sign of inflammation. Third stage, progressive vasodilatation that elevates the local hydrostatic pressure and transudation of fluid in the extravascular wall space develop at this stage. And sure, you will see swelling. Fourth stage, slowing or stasis, increased concentration of red blood cells and thus raised blood viscosity in the area in the site of injury of inflammatory reaction. Hemodynamic changes either includes leukocytic margination, that means peripheral orientation of leukocytes, mainly neutrophils along the vascular endothelium, and this stage characterized by stick to the vascular endothelium briefly, move and migrate through the gaps between the endothelial cells extravascular space. This process is known as like immigration. I want to emphasize that neutrophils is specific cells of acute inflammation. On this slide, you can find the next changes in the microvasculature. There are hyperemia, arterial hyperemia of vessel and edema in the surrounding tissue, and this hyperemia certainly will correlate with stasis. Okay, mechanisms of increased vascular permeability include endothelial cells contraction leading to the intercellular gaps in post-capillary venules, endothelial injury, increased transudates, and leakage from new blood vessels. Endothelial cell contraction occur rapidly after binding of histamine, bradykinin, leukotriene, and many other mediators to specific receptors, and is usually short-lived. A slower and more prolonged reaction of endothelial cells resulting from changes in the cytoskeleton may be induced by cytokines such as tumor necrosis factor and interleukin-1. This reaction may take 4 to 6 hours to develop after the initial trigger and persist for 24 hours or more. Endothelial injury, direct injury, results in vascular leakage by causing endothelial cells necrosis and detachment. Endothelial cells are damaged after severe injury, such as with burns and some infections. Other examples of mild or moderate direct endothelial injury are thermal injury, certain bacterial toxins, and X or ultraviolet radiation. Endothelial cells may also be damaged as a consequence of leukocyte accumulation along the vessel wall. Activated leukocytes release many toxins and may cause endothelial injury or even detachment. Increased transudates of protein by way of intracellular vesicular pathway augments venular permeability, especially after exposure of certain mediators such as vascular endothelial growth factor. Leakage from new blood vessels characterized by the next fact. These new vessels remain leaky due to proliferating of endothelial cells that not so major at this moment, and the intracellular junction is not established. So due to this fact, new formed vessels may show you higher vascular permeability than major vessels. So let's summarize vascular reaction and acute inflammation. Vasodilatation is induced by chemical mediators such as histamine, and is the cause of erythema and stasis of blood flow. Increased vascular permeability is induced by histamine, kinins, and other mediators that produce gaps between endothelial cells, but direct or leukocyte-induced endothelial injury by increased passage of fluid through the endothelium, and this increased permeability allows plasma protein and leukocytes to enter sites of infection or tissue damage. Fluid leak through the blood vessel result in edema, and we name this inflammatory liquid like exudate, don't forget. So we discussed hemodynamic events. Now it's time for cellular events. This cellular phase of inflammation consists of two processes like leukocyte recruitment and leukocyte activation. I would like to emphasize that an important function of inflammatory response is to deliver leukocyte to a site of injury and to activate them. Leukocytes ingest offending agents, kill bacteria and other microbes, and eliminate necrotic tissue and foreign substances. A price that is paid for the defensive potency of leukocyte is that once activated, they may induce tissue damage and prolong inflammation. Since the leukocyte product that's destroyed microbes can also injure normal host tissue. So now it's time to leukocyte recruitment discussion, and this phase includes migration, margination, and rolling along the vessel wall. Next stage, firm adhesion to the endothelium. Third stage, transmigration of the leukocyte through the endothelial cells, and migration in interstitial tissue toward the chemotactic stimulus. So, first stage, margination and rolling. Process of leukocyte accumulation in the periphery of vessel is called margination. If the endothelial cells are activated by cytokines and other mediators produced locally, they express adhesive molecules to which the leukocytes attached loosely. These cells bind and detach and thus begin to tumble on the endothelial surface, a process called rolling. So after activation by cytokines and chemokines, endothelial cells express on the surface specific proteins that we name selectins that are realized function of the leukocyte rolling. The weak and transient interaction involved in rolling are mediated by selectin family and adhesion molecules. Selectins are receptors expressed on leukocytes and endothelium that contain an extravascular domain that binds sugar. The three members of this family are E-selectin, expressed on endothelial cell, P-selectin, present on platelets and endothelium either, and L-selectin on the surface of most leukocytes. Selectins by Lewis X modified glycoprotein that are attached to mucin-like glycoproteins of various cells. So, first step of leukocyte recruitment is the endothelial cells at sites of inflammatory have increased expression of E and P selectins. In step 2, neutrophils weakly bind to the endothelial cells and roll along the surface. So next stage, adhesion. This adhesion is mediated by integrins expressed on leukocyte cell surface, interacting with their ligands on the endothelial cells. Integrins are normally expressed on leukocyte plasma membrane in a low affinity form and do not adhere to their specific ligands until the leukocytes are activated by chemokine. So after the activation by chemokine, the integrin on the surface of leukocytes transform and become high affinity. So, at the same time, the cytokines activate endothelial cells to increase their expression of ligands for integrin. These ligands include intracellular adhesion molecule 1, intracellular adhesion molecule 1, which bind to integrin's leukocytes function-associated antigen, and macrophage 1 antigen and vascular cell adhesion molecule, which binds to the integrin very late for antigen. Engagement of integrin by their ligands delivers signals to leukocytes that lead to cytoskeleton changes that mediate firm attachment to the substances. So, this table is about selectins and integrins that can be expressed on the surface of the main components of this fan. On the endothelium, you can find P and E selectin. Leukocytes ligand is Lewis X and PCGL1, and L-selectin either. And integrins, the interaction between integrins realized due to ICAM1 and LFA1, MAC1, and VCAM1 and VLA4. VLA form. So last stage, transmigration. After being arrested on the endothelial surface, leukocyte migrates through the vessel wall primarily by squeezing between cells at intracellular junctions. The extravasation of leukocytes, called diapedesis, occur mainly in the venules of the systemic vasculature. It has also been noted in capillaries in the pulmonary circulation. Migration of leukocytes is driven by chemokines. In addition, platelet and endothelial cell adhesion molecule become one. Cellular adhesion molecule expressed on leukocytes and endothelial cells mediate the binding event needed for leukocytes to transverse the endothelium. And here, when our leukocyte arrive in the area of injury, may realize its function. So what does it mean, chemotaxis? After extravasating from the blood, leukocytes migrate towards sites of infection or injury along a chemical gradient by a process called chemotaxis. Potent chemotactic substances or chemokine for neutrophils are bacterial products, cytokines, especially those of chemokine family, components of complement system, particularly C5, products of lipoxygenase pathway of arachidonic acid metabolism, particularly leukotriene B4. The type of migrating leukocytes varies with the age of inflammatory response and with the type of stimulus. What I mean, neutrophils predominate in the inflammatory infiltrate during the first 6 to 24 hours and are replaced by monocytes in 24-48 hours. On these microphotographs, you can find inflammatory reaction in the myocardium after ischemic necrosis after the infarction. Early neutrophilic, as you remember, with segmented nucleus, infiltrates neutrophilic cells are congested blood vessel reflect on this photo. Later, mononuclear cellular infiltrates are present in the extracellular matrix. So mononuclear means with round-shaped nucleus, right? And the approximate kinetic of edema and cellular infiltration on these states. So first of all, develop edema. After that, neutrophil infiltration and monocyte macrophages infiltrate like the third wave of inflammatory reaction. So, sum up. Leukocyte recruitment and to sites of inflammation means that leukocytes are recruited from the blood into the extravascular tissue where infectious pathogens or damaged tissue may be located and are activated to perform their function. Leukocyte recruitment is a multi-step process consisting of loose attachment and rolling on endothelium, mediated by selectins, firm attachment to endothelium mediated by integrins, and migration through the endothelial spaces. So various cytokines promote expression of selectins and integrins ligands on endothelium, increase the avidity of integrins for their ligands, and promote directional migration of leukocytes. Many of these cytokines are produced by tissue macrophages and other cells responding to pathogens or damaged tissue. Neutrophils predominate in the early inflammatory infiltrate and are later replaced by macrophages. So, second step in the cellular events during inflammatory response is leukocyte activation. So we know different function of the leukocyte, like phagocytosis of the particles, intracellular destruction of phagocytosed microbes and dead cells, liberation of substances that destroy extracellular microbes and dead tissue, production of mediators that amplify the inflammatory reaction by recruiting and activating more leukocytes. Different classes of cell surface receptors of leukocytes recognize different stimuli, like chemokines, like lipid mediators, and others. The receptors initiate response that mediate the function of the leukocytes. For example, chemokines may activate G protein complex receptors, and cytoskeletal changes occur in the leukocyte, and signal transduction is activated. This can lead to the increased integrin avidity and adhesion to endothelium, for example, or may be a reason of chemotaxis and migration of the leukocyte into the surrounding tissue. Either microbes through the toll receptors may activate leukocytes and push them product mediators like cytokines and arachidonic acid metabolites. And these release and activate, amplificate the inflammatory reaction. Other cytokines may activate cytokine receptor and realize production of the reactive oxygen species, ROS, and lysosomal enzymes, and take a part in the microbicidal activity of the leukocytes and killing microbes. Either the phagocytic receptors may activate phagocytosis of the microbe into the phagosome and killing the microbes. Stages of phagocytosis. First, recognition and attachment of the particle to the ingestive leukocyte. Engulfment with subsequent formation of phagocytic vacuole. And third stage, killing and degradation of ingested material. So, stages of phagocytosis. First stage, recognition and attachment. Recognition of microbes realized due to such specific proteins like opsonins. Opsonins are host proteins that can be recognized by leukocyte receptors. Opsonins coat microbes to enhance their detection and phagocytosis. Important opsonins include the Fc portion of IgG isotope and complement system product C3b, and plasma proteins such as collectins, which bind to bacterial cell walls. The opsonins either are present in the blood, ready to coat microbes. So, leukocytes express receptors for opsonins that facilitate rapid phagocytosis of the coated microbes. These receptors include the Fc receptor for IgG and for complement system components either. Engulfment, second stage of phagocytosis, occurs when the neutrophils sends out cytoplasmic process that surround the bacteria. Phagocyte membrane zips up around microbe. The bacteria are then internalized within a phagosome. The phagosome fuses with lysosome and the granulation stage is occurred. So microbe ingested in phagosome, and after that develop fusion with phagosome, with lysosome, and the granulation of lysosome content. Next stage, killing and degradation. How does realize this stage? This stage may be realized due to most important microbicidal substances like reactive oxygen species, ROS, and lysosomal enzymes and nitric oxide (NO) that act in the same way like ROS. So, in oxygen-dependent killing, respiratory burst requires oxygen and NADPH oxidase and produce superoxide hydroxyl radicals and hydrogen peroxide. Myeloperoxidase requires hydrogen peroxide and halide and produce hypochlorous acid. Oxygen-independent killing involves lysozyme, lactoferrin, and acid hydrolases. So, leukocytes use various receptors to sense the presence of microbes, dead cells, as we told previously. Engagement of these cellular receptors induce a number of responses in leukocytes that are part of their normal defensive function and are grouped under the term leukocyte activation. So, liberation of substances that destroyed extracellular microbes and the tissue belong to the leukocyte activation. But not only releasing of the enzymes responsible for extracellular ingestion, but also the neutrophilic extracellular traps are responsible for this. These nets are extracellular fibrillar network that are produced by neutrophils. Nets contain, and now only imagine, a framework of nuclear chromatin with embedded granule proteins such as antimicrobial peptides and enzymes. And this slide is described this phenomenon like that we name neutrophil extracellular traps. This is healthy neutrophils with nuclei stained red and cytoplasm green. Release of nuclear material from neutrophils you can find on this slide. So this one neutrophil, this another, but we cannot find nucleus inside. Why? Because we receive releasing of the nuclear material outside. And this material is a trap, forming extracellular trap. And this slide is electron microphotograph of bacteria, staphylococci, trapped in the nets. Neutrophil extracellular trap. So, leukocytes effector mechanism. Leukocytes can eliminate microbes and dead cells by phagocytosis, followed by their destruction in phagolysosomes. Destruction is caused by free radicals like ROS and NO, and generated in activated leukocytes and lysozymal enzymes. Enzymes and ROS may be released into the extracellular environment either, and the mechanisms that function to eliminate microbes and dead cells are also capable to damage normal tissue. The pathological consequence of inflammation is acute in this case. So now it's time to talk about chemical mediators and regulators of inflammation. Chemical mediators are responsible for vascular and cellular events of inflammatory response. Knowledge of these mediators, basis of anti-inflammatory drugs. It may either of two types, cell-derived, produced locally by cells at the site of inflammation, and plasma-derived, mainly from liver, and some mediators are derived from necrotic cells. So this slide describes different examples of cell-derived mediators. Source of these mediators, for example, preform mediators in secretory granules of mast cells, basophils, platelets, like histamine, serotonin. Newly synthesized, like prostaglandins, like cytokines, different leukocytes, and even nerve fibers. And plasma protein-derived mediators, major source is the liver. Liver releases these mediators in the plasma, and there are two main groups, like complement system, Kinin system, and coagulation fibrinolysis system. So we know different groups just at glance: vasoactive amines, histamine, serotonin, Kinin system, responsible for the pain, bronchoconstriction, and vasodilation either. arachidonic acid products like cyclooxygenase pathway and lipoxygenase pathway. You know that a lot of NSAID drugs, non-steroidal anti-inflammatory drugs, based on blockage of these mediators and this synthesis of these mediators. Important products in the complement cascades either belong to the mediators of inflammation. And cytokines. Cytokines like interleukin-1 cause fever, interleukin 8 are responsible for neutrophil chemoattractants and produced by macrophages. Role of mediators in inflammatory reaction. Vasodilation. Responsible mediators: prostaglandin, nitric oxide, and histamine. Increased vascular permeability. Set of mediators, lot of them, like histamine, serotonin, bradykinin, leukotriene, etc. Chemotaxis, leukocyte recruitment and activation. Tumor necrosis factor, interleukin-1, chemokines, complement system components, leukotriene, bacterial products. FIVA, interleukin-1, tumor necrosis factors, and prostaglandins. Pain, prostaglandins, bradykinin, and tissue damage either take a role of mediators of inflammation, and it can be lysosomal enzymes of leukocytes, reactive oxygen species, and nitric oxide. Outcomes of inflammation. There are 4 variants of consequences of acute inflammation, like complete resolution with regeneration, complete resolution with scarring, abscess formation after that, healing and scarring, and transition to the chronic form. Usually due to viral infection, chronic infection, persistent injury, and autoimmune disease. Now it's time to talk about morphology of acute inflammatory reaction. We know different types of acute inflammation, and we classify acute inflammation according to the exudate content. So I want to remind you that exudate is inflammatory liquid that accumulate in the extravascular tissue. So, and when we will analyze this liquid, we may classify this inflammation into the next group: serous inflammation, fibrinous inflammation, pseudomembranous inflammation, suppurative inflammation, and abscess formation, hemorrhagic inflammation, catarrhal inflammation. Either we should to say about ulcer, like a morphologic type of acute inflammation, cellulitis, and bacterial infection of the blood. So, serous inflammation, what is that? Marked by outpouring of watery, relatively protein-poor fluid. Derives either from the plasma or secretions of mesothelial cells lining the peritoneal, pleural, and pericardial cavities. Fluid in the serous cavity is called infusion. I guess you know this term from the previous topic, hemodynamic disorders. What about the example? Skin blister. Skin blister is a example of serous inflammation, may form due to burn or viral infection, and characterized by accumulation of serous effusion under the epidermis of the skin. This is serous inflammation grossly. How does it appear with naked eye? You can see this blister and epidermis that more whitish than surrounding tissue. Microscopically, you see this epidermal layer, dermal layer, and this gap that filled by watery liquid. This liquid is exudate. What can I see? Either I can see inflammatory cells. I can see a lot of inflammatory cells in the superficial dermal layer. Fibrinous inflammation, another example of inflammatory acute inflammation, developed due to greater vascular permeability that allows large molecules like fibrinogen to pass the endothelial barrier. Fibrinous exudate is characteristic of inflammatory in the lining of body cavities such as meninges, pericardium, and pleura, for example. Fibrinous exudate removed by fibrinolysis and clearing of other debris by macrophages. If fibrin is not removed, It can stimulate growth of fibroblasts and blood vessels, lead to the scarring and conversion of fibrinous exudate to scar tissue we name like organization. Organization of fibrinous pericardial exudate, for example, form dense fibrous scar tissue that breach or obliterates the pericardial space and restrict myocardial function. So this is an example of gross specimen of fibrinous inflammation in the pericardial sac. You can see this fibrin network between visceral and parietal layers of pericardium. And if this fibrin will not resolve, this tissue can be replaced by connective tissue and scar tissue will form. Fibrinous inflammatory microscopically in the pericardium appear like this homogeneous eosinophilic meshwork on the surface. This is fibrin acellular material, exudate material, and the visceral on the surface of visceral pericardium. This is vessel and this is myocardium. So the membranous inflammation. It is inflammatory response of mucous surface, oral, respiratory, bowel, to a powerful necrotizing toxins of diphtheria or irritant gases, characterized by formation on a mucosal surface, a false membrane composed of precipitates of fibrin, necrotic epithelium, and inflammatory leukocyte. This is gross examination of the large intestinal tract mucosa, and you can find this false membrane on the surface that cover mucosal layer. Microscopically, pseudomembranous colitis characterized by a fibrin cap on the surface of the epithelial cells. Another example, pseudomembranous pharyngitis during diphtheria. So you see this false membrane on the surface of the oral cavity. Suppurative inflammation is another example of acute inflammatory reaction and characterized by a collection of large amount of purulent exudate or pus, consisting of neutrophils, necrotic cells, and edema fluid. Certain organisms like Staphylococci are more likely to induce such localized suppuration and are therefore referred to as pyogenic pus forming. Example, acute appendicitis. So this is acute appendicitis, grossly phlegmonous form means diffuse purulent inflammation. How can I conclude that I work in this case with purulent inflammation? Because I can find this yellowish greenish exudate material on the surface of inflamed appendix. So pus usually has specific color, yellowish or greenish, characterized by high viscosity and like soft, like cream. You can describe it like cream consistence of exudate, purulent exudate. So microscopically, if you will take piece of this appendicitis and analyze microscopically this tissue, you can recognize the next changes. You will see significant inflammatory infiltration by neutrophils of the entire layers of the appendix wall. So what else can I find here? I can find mucus layer and interruption and disturbance, breakdown of this epithelial layer. So we name it like erosion, ulcer. It is either sign of acute inflammatory response. Another example, suppurative inflammation of the meningitis, purulent meningitis. What can I find? I can find once again this yellowish greenish exudate above the meninx, Microscopically, brain tissue and inflammatory cells, hyperemic vessels and brain tissue. This is suppurative inflammation of the pericardial cavity. Once again, you can see this specific colored exudate in the pericardial sac. This is purulent pericarditis. Pleural empyema means diffuse purulent inflammation in the pleural cavity. Here I can find lung, and this is a lot of pus in the in the thoracal cavity, pleural emphysema. So lobar pneumonia is an example of another variant of inflammation. So for comparison, this is variant of Krupus of fibrinous inflammation. So suppurative inflammation within the alveolar space microscopically. What can I find? Honestly speaking, I can find air in these lungs. I can find only inflammatory liquid inside the alveolar space. And this liquid consists of a lot of neutrophils, RBC, fibrin, debris, tissue debris, and hyperemic vessels with stages either recognizable. Higher magnification, suppurative inflammation still discussing, and hyperemic vessels with neutrophil contents inside of the alveolar space. So we either know focal local form of suppurative inflammation. For this case we use term abscess. So abscesses are focal collections of the pus that may be caused by seeding of pathogenic organisms into the tissue or secondary infection or necrotic foci. Abscess is composed of numerous dead as well as living neutrophils, some red cells, fragments of tissue debris, and fibrin. In old pus, macrophages and cholesterols crystal can be recognized. So on this slide, you can find cut section of the lungs with lung abscess on the periphery. How I know it? I can see this cavity with fibrous wall. This is bronchial tree and bronchial lumen. That's not abscess, don't be confused. So abscess is here. So this is either abscesses of the lung, but acute form, because I see only infiltration and accumulation of a lot of inflammatory cells in the cut tissue of this lung. So abscesses typically have a central, largely necrotic region ringed by a layer of preserved neutrophils with a surrounding zones of dilated vessels and fibroblast proliferation indicative of attempted repair. As time passes, the abscess may become completely walled off and eventually be replaced by connective tissue. So this connective tissue wall of chronic abscess we know like pyogenic membrane. So microscopically, I can recognize abscess like a collection of neutrophils, macrophages, and tissue debris in the organ. Once again, micro abscess but at higher examination. And we know specific form of suppurative inflammation, skin forms like furuncle or boils, which is an acute inflammatory via hair follicles in the dermal tissue inflammation, and carbuncle is a cluster of boils draining pus into the skin. Microscopically, furuncle appear like accumulation of inflammatory cell near the follicle, and this is epidermis, derma, and inflammatory infiltrate. Next type of inflammation is ulcer, local defect or of the surface of organ or tissue produced by sloughing, shedding of inflamed necrotic tissue, most commonly encountered into the mucosa of the mouth, stomach, intestines, or genitourinary tract. Skin and subcutaneous tissue of the lower extremities of the person either may show you this variant of inflammation, ulcer. Why? Due to circulatory disturbances. This is stomach ulcer. What can I see? I can see mucosa, and I can see definitely easily recognizable defect with clear borders. So in this case, I work with ulcer. Microscopically, inflammatory cells and mucosal layer defect. Cellular debris either recognizable here, and fibrinoid necrosis. In the underlying tissue, you may recognize granulation tissue. Granulation tissue is a major connective tissue, but this issue of your next lecture. Laryngeal ulceration you may find here, and cutaneous ulceration due to disturbances of blood supply. And just for a glance, let's discuss the last types of inflammatory reaction, like lateral inflammation, a surface inflammatory reaction associated with greatly increased secretion of clear mucus. Usually this type of inflammation develops in the upper respiratory tract. Hemorrhagic inflammation, where the damage is severe, actual rupture of all blood vessels occur, with hemorrhage the most striking feature. Acute hemorrhagic pneumonia is an example of this type of inflammation, occur in fatal cases of influenza, plague, and anthrax. Cellulitis, what is that? From the pathomorphologic point of view, is a diffuse inflammation of the soft tissues resulting from the spreading effects of substances like hyaluronidase released by some bacteria. And bacterial infection of the blood includes bacteremia, septicemia, and pyemia. You will study this topic during the last practical class of the entire course. So now it's time for the chronic inflammation. Chronic inflammation, it is inflammation of prolonged duration, weeks to years, in which continuing inflammation, tissue injury, and healing often by fibrosis proceed simultaneously. Chronic inflammation may arise in the following settings: persistence of infections by microbes that are difficult to irradiate. This includes Mycobacterium tuberculosis, Treponema pallidum, immune-mediated inflammatory disease, and prolonged exposure to potential toxic agents either can be a reason of chronic inflammation. Exogenous materials such as inhaled particulate silica, which can induce a chronic inflammatory response in the lungs, and endogenous agents such as cholesterol crystal, which may contribute to atherosclerosis. So we have three main ways of chronic inflammation development, like chronic inflammation following acute form, recurrent attacks of acute inflammation, and chronic inflammation starting de novo. What about the general characteristics of chronic inflammation? In this case, we have to say about mononuclear cell infiltration. Mononuclear cells are macrophages mainly and lymphocytes. And I would like to emphasize here that although the presence of neutrophils is hallmark of acute inflammation, once again, neutrophils is hallmark of acute inflammation, many forms of chronic inflammation may continue to show extensive neutrophilic infiltrates as a result of either persistence of microbes or necrotic cells, or mediators elaborated by macrophages. Such inflammatory lesions are sometimes called acute or chronic. What else can we say about general features of chronic inflammation? Tissue destruction or necrosis either occur in the site of injury, but proliferative changes are significant. This picture is about co-stimulation of T lymphocytes and macrophages during the inflammatory response. As you can see, macrophage in classical macrophage activation may release cytokines and activate T lymphocytes. T lymphocytes activate another activated T lymphocytes may release cytokines like interleukin 17 and tumor necrosis factors and amplify inflammatory reaction, leukocyte recruitment, inflammatory, and release once again interferon gamma and activate macrophages. So these cells are co-stimulate each other and amplify inflammatory reaction. What about the systemic effects of chronic inflammation? In this case, we have to say about fever, anemia, leukocytosis, erythrocyte excitation rate at the high level, and amyloidosis. Classification of chronic inflammation. There are two main types: chronic non-specific inflammation, sometimes we use term diffuse interstitial inflammation, and granulomatous inflammation. Chronic inflammatory reaction in the lungs microscopically. In this case, we can describe like collection of the chronic inflammatory cells here. Destruction of parenchyma. Normal alveoli are replaced by cuboidal epithelium, and replaced by connective tissue of the lung interstitium. So you can see fibrosis here. So accumulation of inflammatory cells, replacement of normal alveolar cells by cuboidal, and significant connective tissue growth. By contrast, in acute inflammation, as if you remember, in the lung, you will see neutrophils in the alveolar space and blood vessels with congestion, with hyperemia. So this is chronic inflammation in the lung. And this is, sorry, that's mistake, it's really mistake, this acute inflammatory. And just compare, in this case, fibrosis and chronic inflammatory cells accumulation in the interstitium, and here you can find hyperemic vessels with inflammatory neutrophils, predominantly cells in the alveolar space. Another variant of chronic inflammation is chronic granulomatous inflammation. It is a specific form of chronic inflammation that characterized by small aggregates of modified macrophages, and these modified forms of macrophages you will name like epithelioid cells and multinuclear giant cells, usually populated by CD4 Th1 lymphocytes. So chronic granulomatous inflammation characterized by granuloma formation, small nodules formation. We know granulomas can form under 4 settings. With persistent T-cell response to certain microbes like Mycobacterium tuberculosis and fungi. In some immune-mediated inflammatory diseases like Crohn's disease, and either we know disease with unknown etiology but with granulomatous type of inflammation like sarcoidosis, and as a response to relatively inert foreign bodies like suture or splinter forming so-called foreign body granuloma. Composition of granuloma is as follows: epithelioid cells located centrally, form when interferon gamma transform macrophages to the epithelioid cells. They are enlarged cells with evident pink cytoplasm. Multinuclear cells, giant cells, another name, located centrally, are formed by fusion of epithelioid cells. Types include Langhans giant cells and foreign body giant cells. I'll show you later the schematical representation of these cells. Lymphocytes and plasma cells are present at the periphery, and central necrosis occurs in granuloma due to excessive enzymatic breakdown and is common seen in Mycobacterium tuberculosis infection as well as fungi infection and a few bacterial infections. Because of this, public health risk of tuberculosis necrotizing granulomas should be considered tuberculosis until proven otherwise. So once again, this scheme that describe interaction and between macrophages and lymphocytes, and this is schematical representation of foreign body giant cells and Langhans giant cells. What an important that both these types is a result of fusion between adjacent epithelioid cells, but foreign body giant cells characterized by nucleus that located centrally, while Langhans type characterized by accumulation arrangement of this nucleus at the periphery, like horseshoe or C, letter C, and in this case we name it like Langhans giant cell. So there are different diseases that develop granulomatous type of inflammation: tuberculosis, leprosis, syphilis, cat scratch disease, sarcoidosis, and Crohn's disease. Tuberculosis. Cause of tuberculosis is Mycobacterium tuberculosis, tissue reaction characterized by the presence of central caseous necrosis, guys, cheesy-like appearance of necrotic mass you will recognize grossly, surrounded by epithelioid cells, lymphocytes, plasma cells, and giant Langhans cells. So with horseshoe appearance arrangement of the nucleus in this giant cell. In contrast, caseous necrosis is rare in other granulomatous inflammation. So this is gross appearance of the granuloma during tuberculosis, and this granular cheesy appearance of the central necrosis is a specific sign of tuberculoma. Microscopically, what can you see? You can see this pink-colored central mass, necrotic mass, giant cell. This is just one cell, and epithelioid cells with pale evident cytoplasm, lymphocytes, and macrophages at the periphery. Syphilis. Treponema pallidum is the cause of this disease. Tissue reaction that developed during this disease is a guma. Microscopic is either granuloma that consists of histiocytes, plasma cells, and central cells are necrotic without loss of cellular outline. So this is pulmonary pustules as manifestation of secondary syphilis grossly. And microscopically, guma consists, as I told you, from the giant cells and epithelioid macrophages cells and macrophages cells. High magnification. Next disease with granuloma formation is leprosy. The main cause is Mycobacterium lepra. Tissue reaction that develop during these diseases, epidermis that contain compliant granulomas composed of macrophages, plasma cells, and leprous Virchow cells. Leprous Virchow cells refer as large foamy macrophages within fatty vacuoles contain leprous mycobacteriums. So this is mildly elevated indurating nodule that's seen on the face and extremities, in this case extremity. Microscopically, the bacilli are densely clustered within the cytoplasmic vacuoles of foamy histiocytes. This unique structure called lobi is demonstrated by Sim-Nielsen stain. So this is violet magenta colored masses is bacilli of the lepra. Skin biopsy shows intradermal formation of epithelioid granulomas without caseous necrosis. The papillary dermis is involved. Acid-fast staining is negative. Diagnostic hints include clinical information of numbness and histologic identification of nerve involvement by the granulomatous lesion. Rhinoscleroma is a chronic granulomatous disease of the upper respiratory tract caused by gram-negative organism Klebsiella rhinoscleromatis. It is uncommon in the United States, but in the Ukraine, but endemic in parts of Central or South America, Egypt, Africa, and Eastern Europe can be endemic. Mucopurulent discharge characterized the rhinitic stage, followed by mucosal thickening during florid stage, seen later. The disease resolves with marked fibrosis and tissue reaction characterized by granuloma sclerosing formation that consists of the plasma cells, epithelioid cells, lymphocytes, and hyaline spheres. Large macrophages with light cytoplasm containing Klebsiella rhinoscleromatis. We name these macrophages like Mikulicz cells, and sclerosis and halitosis take part. This is nodules during florid stage of rhinoscleroma. You can see the significant densening of the skin and the mucosal thickening either. And these globules easily recognize microscopically. And also you may see lymphocytes and plasma cells. Sarcoidosis causes unknown, tissue reaction known, causating granulomas with evident activated macrophages. These patches on the surface of skin is a feature of the sarcoidosis, granulomatous inflammation, nodular inflammation. And last example, foreign body granulomas can be initiated by relatively inherent foreign bodies form around materials like talc, for example, or suture material. Foreign material can be identified in the center of meningioma. And this is foreign body giant cell reaction to aspirated vegetable material. So, and this is, guys, giant cell, but foreign body giant cell with centrally located nucleus. Foreign body giant cell reaction to the suture material. This is suture material, and this is giant cell. This is just one cell with a lot of nucleus inside. What about systemic effects of inflammatory reaction? We have to say about fever, elevated plasma level of acute phase protein, leukocytosis, lymphangitis, and septic shock. But I want to say that certainly almost all of them are signs of acute inflammation, but some of them can either be recognized during chronic form. Let's summarize our lecture. Let's highlight main moments. So, acute inflammation is an immediate response to injury or infection that can cause redness, heat, swelling, pain, and loss of function. Hemodynamic changes in acute inflammation are mediated by vasoactive chemical, and after a transient initial vasoconstriction, produce massive dilatation with increased vascular permeability. Neutrophils are important white blood cells in acute inflammation. They contain granules with many degradative enzymes. Neutrophils leave the bloodstream in a highly regulated process involving migration, adhesion, and immigration. Defects in adhesion can contribute to immunosuppression seen in diabetes mellitus and corticosteroid use. Chemotaxis is an attraction of cell toward the chemical mediators, which is released in the area of inflammation. The phagocytosis of the bacteria by neutrophils is improved if opsonine, such as of Fc portion of IgG, or complement products are bound to the surface of microbe. Hagashi syndrome is an example of a genetic disease with defective neutrophils degranulation. Once a bacterium has been phagocytized, both oxygen-requiring and oxygen-independent enzymes can contribute to the killing of the bacteria. Chronic granulomatous inflammation and disease of childhood and myeloperoxidase deficiency are genetic immunodeficiencies related to defects of the oxygen-dependent kidney. Chemical mediators of inflammatory reaction include vasoactive amines, Kinin system, arachidonic acid products, and the complement cascade and cytokines. Inflammation may result in tissue regeneration, scarring, abscess formation, or chronic inflammation. Cells important in the chronic inflammation include macrophages, lymphocytes, eosinophils, and basophils. Chronic inflammation, particularly granulomatous type, is a specialized form of chronic inflammation with modified macrophages into the epithelioid cells or multinuclear giant cells, usually surrounded by a rim of lymphocytes. A wide variety of diseases can cause chronic granulomatous inflammation. There are tuberculosis, syphilis, leprosy, and fungal infection. That's all, guys. Thank you for your attention.